Well, thank you very much indeed, Madam Chairman. It is a great pleasure. I'm just going to try and get this up. There we go. To be able to provide an update. And this will be, let me say, not the first, but I think the fourth update that I've been able to provide from the Garfield AF program, for the South African Society. And it's a great pleasure to do so because we are in a position to appreciate and recognize the important contribution that has been made by colleagues in South Africa to this program. These are my disclosures. And just to remind members of the Society about the Garfield-AF program, it's one of the largest prospective AF registries in the world, probably the largest. Newly diagnosed patients with atrial fibrillation within 6 weeks of their diagnosis included in the registry from 35 countries, over 1,300 investigational sites that were randomly selected, representing different national AF care settings. Some 57,000 patients enrolled over 5 sequential cohorts and followed for between 2 and 8 years, depending upon which cohort they were included in. Now, at the outset, we decided that we wished to look at our data in a systematic fashion, understanding what they told us about the burden of disease, risk stratification, treatment practices, therapeutic persistence, clinical outcomes, geographical outcomes, and health economics. So we have taken a very systematic approach to a data set, 20% of which has undergone physical source data verification at site, 100% undergoing electronic continuous evaluation of data submitted to the central data sets. And let's just look at findings that we've published in the last year or so from the Garfield program. But before I do that, I just want to remind colleagues about the power of having a prospective registry and following patients over sequential cohorts, all defined a priori, because we've been able to demonstrate across the 57,000 patients how patterns of practice have evolved over the period of recruitment since 2010. You can see in cohort 1 on the left of the slide that blue, the use of vitamin K antagonists plus or minus antiplatelet therapy was the principal intervention. The green, antiplatelet therapy alone, still seen as the principal intervention in large numbers of AF patients presenting with a risk for stroke. The purple, about 10% consistently across the cohorts of patients who are recognized by their clinicians to have important stroke risk, but where the choice of the clinician is not to intervene in any form of therapy. Over time, that has remained stubbornly high. Antiplatelet therapy has reduced. The use of VKAs has reduced, but you can see the red segment in the middle here, an increase in the use of the direct oral anticoagulants over that period of time. And overall, over the 5 cohorts, about 5 to 6 years of recruitment, anticoagulation at baseline in patients considered at risk of stroke has increased from 57 to 71% of the population. You can see here marked the patterns of practice for patients recruited in South Africa. And you can see, firstly, important variations across the globe in how we intervene in patients. But you can see in South Africa, principally intervention with a VKA antagonist plus or minus antiplatelet therapy, the light blue and dark blue, with an important use still of antiplatelet therapy as the principal intervention in AF patients. Now let's look at therapy persistence. Well, we've done some analysis to see in the overall patient population how patients started on one anticoagulant switch, and you can see over here amongst all patients who started on a factor Xa inhibitor, a small number, 0.6%, switched to a direct thrombin inhibitor over time, and 2.2% to a vitamin K antagonist. For those who started on a DTI, 3.2% to a VKA, 7.1% to a Xa inhibitor. And for those who started on a VKA, 2.2% to a DTI, 6.7% to a VKA. If you look at those data in terms of switches in amongst patients who switch, you can see over here for factor Xa inhibitors, for those who switched, 23% to a DTI, 76% to a VKA. for those who started on a DTI, some 30% to a VKA, 69% to a 10A inhibitor. And for those who started on a VKA, 24% to a DTI and 75% to a 10A inhibitor. So it is interesting to understand in a real-world population, unselected at baseline, where clinician choice was the determinant of how patients should be treated, what patterns of practice are. If you look at discontinuation, this is for greater than 7 days, over the last three cohorts, cohorts 3, 4, and 5, you can see that the discontinuation rate for anticoagulation is falling, but you can see that the greatest risk of permanent discontinuation by baseline treatment is for those patients receiving a direct thrombin inhibitor at baseline. What is the impact of discontinuation at 2 years of follow-up in patients with newly diagnosed atrial fibrillation? Well, you can see here the hazard ratios compared to patients who didn't discontinue their anticoagulation, poor clinical outcomes in terms of the composite of death, non-hemorrhagic stroke, MI, and in particular here, if one looks at death and non-hemorrhagic stroke and myocardial infarction broken down, there is clearly an important association between discontinuation and poor clinical outcome. Of course, there may be other factors driving the reasons for that discontinuation, which are also associated with a higher risk for these clinical endpoints. If one looks at clinical outcomes, it's interesting to use the validated and quite fastidious tools for comparative effectiveness that have been established in the last few years to ask questions about whether there are differences in outcomes for different patient populations in the GARFIELD-AF registry. If we look at all-cause mortality, for instance, the dark blue dot unadjusted and the lighter blue square adjusted data, if one looks at first patients receiving an oral anticoagulant versus no anticoagulation with newly diagnosed atrial fibrillation and risk of stroke, you can see that use of an oral anticoagulant of any kind compared to no anticoagulation is associated with an important reduction in all-cause mortality, non-hemorrhagic stroke and systemic embolization, but of course with an increase in major bleeding. If one goes to the right-hand side of this slide and looks for the comparative effectiveness of patients who were prescribed one of the novel oral anticoagulants, direct oral anticoagulants, compared to a vitamin K antagonist, you can see again benefits in terms of all-cause mortality, less pronounced, but nevertheless some suggestion of benefit with regard to stroke. But interestingly, when you look at the comparison of the direct oral anticoagulants versus the VKA, an important benefit for the direct oral anticoagulants in terms of a lower rate of major bleeding when compared to vitamin K antagonists. So quite striking. In a large unselected population of newly presenting patients with AF, the real benefits in terms of the direct oral anticoagulants over the vitamin K antagonists is in terms of all-cause mortality reduction and a reduction in major bleeding. If we then look at higher risk populations, again, here the comparison, a direct oral anticoagulant versus a VKA, you can see that in elderly patients, the benefit is maintained, particularly with regard to mortality and major bleeding for those receiving one of the direct oral anticoagulants. A high bleeding risk population, again, a mortality benefit in favor of the NOACs, impaired kidney function, benefit again of the NOACs across all-cause mortality, and then a trend towards benefits in terms of stroke and major bleeding. And then extremely obese patients, again, a benefit in terms of all-cause mortality. One of the other things that we've been able to do in the GARFIELD data set, bearing in mind we have some 57,000 patients, is to see whether we can replicate results from the RCTs or try and replicate randomized controlled trials in the data set. So here you can see, for instance, in the top part of this slide, pulling out patients who met the ROCKET-AF trial entry criteria, and then looking at the performance of patients in the registry compared to a VKA in each case for apixaban or rivaroxaban. And similarly, if you look in the bottom half of this slide, pulling patients out from the registry who met the Aristotle criteria, and then looking at the performance of the interventions in these patients, whether they received apixaban or rivaroxaban compared to VKA patients meeting those criteria. And it is quite striking that you can start to see differences in the performance of these interventions, suggesting, of course, that the selection of inclusion and exclusion criteria for the randomized trials have an important impact on the outcomes in those studies, as is fully intuitive, and that we need to be sensitive about understanding that when we interpret those data. And so too, you can see here now the RCT results for the definitive trials, Aristotle and Rocket, and the effect seen in the GARFIELD population of patients with a CHA DS VASC of equal or greater than 2. And you can see, in general, a consistency between the RCT result and the performance of patients in the GARFIELD-AF registry. The GARFIELD-AF registry patients, the dark red spot, the Aristotle trial results, the blue, and the Rocket-AF results in the lower panel, the orange. So in summary, Madam Chairman, what we've been able to do in the GARFIELD-AF registry is to establish quite a high global data set, research quality data, which now can be used both for the analyses that I've described, but increasingly to develop new tools in terms of comparative effectiveness and use of data using new data science tools to help us develop risk scores and to make assessments that you indeed were able to show in the presentation on GARFIELD VTE. We've been able to assess temporal trends, determine geographical differences, explore the randomized controlled trial results in the real world setting, and as I say, apply methods of comparative effectiveness in broad, unselected patient populations. Thank you very much indeed.
Thank you very much, Ajay, for this excellent talk, and in particular for sharing these clinically relevant messages with us. I think we may have time for 1 or 2 questions. I can't see the chat box so far. Are there? Well, just a comment from my... Pardon? Barry?
No, it's fine. I just wanted to say we must keep to time. That's all.
Yeah, then let me finish this excellent presentation with just a comment. Ajay, I'm very grateful that you mentioned the comparative effectiveness analyses also for AF, comparing VKA and DOACs or NOACs. And here, perhaps due to the different patient population, but perhaps also just because of the much higher numbers of patients in AF registry when compared to VTE, you were able to confirm that major bleeding was also significantly decreased in the DOAC group. So for VTE patients, it went in the same direction, but not statistically significant, but for AF, it became statistically significant. And I think that is a major major achievement in favor of the DOAC treatment, safer treatment for the patients.
Absolutely.
So I think we need to move on, as Barry said. Thank you so much.